Okay, you're live.
Thank
Yeah.
you.
So, hello everyone. Today we have an interesting session on uterine transplant, which will be deliberated by Dr. Padma Priya. She's the director of Uterine Transplant Program at Glen Angels Global, Chennai. And Madam has vast experience in screening and dealing with the patients of uterine transplant. So, we will hear more about uterine transplant from her with her practical knowledge and the difficulties that she has faced during this whole process. So, madam, I welcome you. So, before we even start this, I mean, what is it that made you take up this project of uterine transplant? You being the first woman in South India. I don't want it to be a gender-based thing, but I think you are the first one in South India to do it. What was it that was going on in your mind when everybody was pushing for surrogacy and when everybody was like, trying an alternative method apart from actually doing the uterine transplant? What was it that triggered you to do it? Because I know it is not a very simple thing to do. It is a very, very, very tough and it requires a lot of mental grit, a lot of coordination from everywhere, a lot of the licenses and things which have to be like kept in mind when we do this sort of huge program. So can you please tell us a few words before we actually go into the scientific part of it?
Ma'am, basically, thank you, ma'am, for the introduction. Basically, I think it's, the situations which put you to do something. And I think where I was practicing was a multi-speciality referral center where we get a lot of Mulian anomalies. And vast majority of them, it was through my patient, who was pushing me to find an alternative to surrogacy when I got connected to the international faculty like Matt Brandstorm, who's definitely all our mentor, and Jerry Fronick, who introduced me to this field of uterine transplant, and of course, Professor Rela. So it was being at the right time at the right place, and us being a transplant center in Gleneagles Global Health City. So basically, that's the whole thing. They're well known for renal transplant, Muruganandam sir, and liver transplant, Joy Varghese sir and team, and heart and lung, a hand transplant, Selva Sitaraman, and of course, uterine transplant. I think it's being in the right time. And of course, my secretary herself was a case of Mullerian anomaly. So my close association with her, MRKH.
And what was the influence of Dr. Rela in all this journey?
Yeah, Prof, I have so much to say that can go on for a session itself. But when I went to Prof, he was the one who actually told me that, you should go ahead. He encouraged me to do it. But above him was Max Brandstorm. I would say he is the person, my mentor. I mean, till date, he's been really supportive. And he'll be coming to Chennai soon to do the next transplant.
You're not talking about Miss Dr. Nicholas?
Yeah, Nicholas as well, his team, Dr. Nicholas as well.
Okay, yeah. So let's get on to the scientific part of it. I mean, what is the indication of uterine transplant in the current scenario in India and in majority, major part of the world? Like, what is the main indication that you come across?
MRKH. See, 1 in 5,000 women, we all know that's the incidence of MRKH. And then there is the second category, which is absolute uterine factor infertility. So if you actually look at the uterine factor infertility, which is removal, it could be hysterectomized patient due to obstetric hysterectomies or previous cancers or a non-functional uterus, be it various other Mullerian anomalies. Mullerian anomalies is not always about MRKH. So if you look at that, that comes up to 1:500. So the pool gets larger when you actually look at absolute uterine factor infertility. So that's the actual incidence, and that is 1 in 5,000 itself is large. But if you look at this 1:500, it's really huge. So that's the actual incidence. And with the new Surrogacy Act and all, there are patients who really want uterine transplant rather than I would say, doctors wanting it or referring it.
Mhm. Okay, tell me, I mean, once you have started this program, have you seen sudden, like, increase in the numbers of Mullerian anomalies who are coming to you?
Yeah,
Have have
definitely. All types of Mullerian anomalies, like right from transverse vaginal septums to biconjugate uterus, all types. So that's how we decided to start a center for Mullerian anomaly for the state in Gleneagles Global Health City. Yeah, a lot. Once we started it, a lot more of referrals. Even for uterine transplant, right now we've recorded around 674 or some, uh, you know, uh, calls and enquiries.
Mm-hmm. So, when was the year that you started this journey? Like, when was it that first that you started, and how many have you done in this past couple of years?
2017, it took 5 years to set up the program from licensing because nobody else had got the license in the state. So to get the licensing, even the people who are coming for license, right? The inspectors, they didn't know what the whole program was all about. So educating even the people who came for inspection and so on and so forth. And we did the first two transplant in 2022, December 6th and 7th.
Okay. And how difficult was it to convince the regulators about the uterine transplant necessity and need? Because it is not a life-saving procedure like how the kidney transplant is or how the liver transplant is. So was it very tough from your end to, like, make them understand and take you seriously when you started doing this whole processes of the regulatory things that was there to
Yeah,
put it?
definitely. It was really a tough job. Actually, getting the license was so difficult because, people wouldn't take it very seriously. As you said it right, it's not a life-saving procedure. But you have to understand, fertility cannot be taken easily. If fertility was so easy, there wouldn't be so many IVF centers across. So we know the, human, the basic instinct is reproduction, and having babies and children. So everybody it's a right, to for them to have their own biological child. And so, even to experience motherhood. And I think this is very good. And actually, with Max Brandstorm, sir, having done everything, it was so easy for the rest of the world to take it forward. I think he had the biggest brunt, and he started off as a trial study. And then his successes was what really encouraged us or inspired us drastically. He's a man of great vision, the pioneer in doing it. So definitely, I think all of us have to bow down to him, for his vision. It's not that easy. And I feel blessed that he's actually mentoring us through this. And, not many people will get this opportunity in their lifetime as well. So basically, it was not a very easy to convince even your own system, but for me, I was in the right place. As I said, my hospital, which is a Singapore-based hospital. So it made things very easy. They had the vision. And since transplant was going on, it was not something very new that they had to listen. They just said, oh, really, uterine transplant? Okay, that's all it took for me in my hospital to say, okay, what do you want to go about it? Our All India CEO, Anurag, everybody, they just had to say, tell us what you want to do and we'll do it. That's it. And but to get the clinical work going, it's a team which is very important. You just cannot start it just like that. It's a big teamwork. So what really clicks in our hospital is the teamwork, I would say, because the list of people who are required is a transplant team, liver transplant team, Dr. Mettu Srinivas Reddy, Dr. Rajinikanth. I mean, I can go on and on and on. Muruganandam, Selva Sitaram, of course, Dr. Joy, Dr. Selva. There is a lot of teamwork going inside this. We need a pediatric hemato-oncologist, Dr. Ponni. We need a nephrologist, Muthukumar. It was a huge team, a team consisting of 37 doctors. I mean, senior consultants. And if you look at the junior consultants, another 15 to 20. It's a huge team effort which goes into it and coordination. And you need your team, they all have huge practices in a private setup. They have to sit down for every clinical meet when we have to go on for the last 5 years. It's not an easy thing. So you need an entire, one person drives it, yes. But the rest of the team, you have to really inspire the team because they can give up on at any point in time. So, It's a huge team effort, and licensing is really a headache. But thanks to our team who came and did it, thanks to Tamil Nadu government as well for giving us. And it's no more a trial study. Right now, we've got it as a treatment. It's a viable option and treatment for uterine transplant, not a trial study anymore.
Okay. So how do you select the patient?
Selection of patient, yeah. Mostly our patients are MRKH patients or patients who've lost their uterus due to previous obstetric, like PPH or abruptio. They've lost their child. They should not have, the indication is no living child, non-functional uterus or absent uterus, MRKH being the easiest, okay? And age group between, they should be married, definitely married. Age group between 18 to 40, okay? And no communicable diseases, of course. And so negative for, they have to be seronegative, and no diabetes, hypertension, because it can affect vessels, you don't need an atherosclerotic vessel because it will lead to hypoperfusion, and that is a very, very big risk. And that's how we screen. And with the donor, luckily for us, both were their own mothers. We get, see, it's not easy to get. We are doing only related donors. We're not doing for unrelated donors, okay? We've not yet started cadaveric program. We're going to start it once we have things in place. I think May, June, we'll start we've got the license for cadaveric program as well. So thanks to the entire team, we got that license as well. We got both license for living and cadaveric transplant for uterine transplant. And I think we'll be the first one to do the cadaveric transplant in India soon. But yeah, that's about it, So it was, it's screening both the donors again, mothers, and they should have completed their family life. And the matching as well, the HLA matching. You have to look for donor-specific antibodies. You have to, the blood group should match. So far, we've done same blood group, and we have to screen them for the MRA and MRV and MR angiogram to look for the size of the vessel sizes, which is very, very important because that is what is needed for anastomosis. We have to screen them explicitly for all the diseases like chlamydia and all, because after immunosuppression, all these things will flare up, right? Torch and everything. And once everything is clear, it's a huge, multiple sessions of counseling and a lot of pre-transplant workup to be done. And then only we select these patients. Basically, if they've had any, so we had one patient who had a single kidney, right? So usually Mulian anomalies are associated with renal anomalies like horseshoe kidneys or single kidney. So one of our patient had a solitary kidney. So we had to do DTPA renogram before we go and, for that solitary kidney function. And then we had to go about doing it. And we have to be very careful because once the gravid uterus is growing, it might really put pressure on that single kidney and we might be really in trouble. So we have to look out for that.
Okay. So what is the preparation process for uterine transplant?
Yeah, first, as soon as the patient comes, you have to sit with them, take their complete history. See, when they come with amenorrhea, you have to do you have to prove that they're genetically female, right? It's not yet proposed for transgenders yet. So it's genetically female. They have to have their own biological child. So their AMH, they have to have a good fertility level. So, and then the first step is you look out physical examination, confirm they are female, confirm their marital status, confirm their mental status. I'm telling you, this is where I think we might go wrong. And this is where the Western countries give a lot of importance, that the basic thing for everything is the mental status. You have to ensure that the patient is first given the option for surrogacy and adoption. If she refuses, only then you can go for uterine transplant. You have to give everything, options to them, counsel them, tell them really what is the success rates and how many have been done in the world and how many you people have done. Clarity, transparency, of course, integrity goes hand in hand. And how you actually go about screening the patient is, first step is vaginoplasty. We have to see whether they have their native vagina or not. If they've not had a native vagina, vaginoplasty. 2, they have to have a good AMH. You have to have at least day 5, 6 to 8 blasts. that is mandatory. Then, of course, you see for the marital status, once the vaginoplasty is done, 6 months to 1 year later, you can go ahead with the transplant. IVF then transplant. 3 months after IVF, you go for the transplant. Then 3 months after transplant, you can start single embryo transfers only, not, no 2 embryos and all. It's always single embryo. Better to do PGS, PGD for all your embryos. And then if you're lucky, it sounds easy. That's where after the transplant is when, you'll have to do the biopsies for them to look for rejection, cervical biopsies. And you also have to look for their immunosuppression levels. That's called the TAC level. You'll have to keep it between 5 to 8. It not should be too high because then you'll have opportunistic infections. Too low goes for rejection. So you'll have to be quite careful about that and then monitor. And then, of course, baby by cesarean section, obviously. 1 or 2 babies maximum, and then you'll have to go for explant. Everything should be done within 5 years because, you don't want to have the effects of immunosuppression on the healthy recipient.
Okay, and what are the types of vaginoplasties that is favorable before the transplant?
Yeah, Vecchioti technique is what everybody uses. Even the intestinal, the pull-through technique, which Jay does. And then for us, Dr. Selvasita Raman, he did the horseshoe technique and then tubularization technique. But for my first 2 patients, I was lucky. I really got lucky. They had native vagina. Yeah. Okay. They had a long native vagina, which was around the ideal length, which is needed is 9 to 11 centimeters. That's when the anastomosis, otherwise it will kink. And again, you can go for hypoperfusion.
So for example, if the patient has had vaginoplasty before, okay, but if the length is like say 7 centimeters or 6 centimeters for whatever reasons post the vaginoplasty, do you ask them to do a repeat vaginoplasty before you go ahead with the transplant?
No, dilatation. We offer them dilatation and they're married, right? So sexual intercourse, repeated sexual intercourse. And if it's really bad and fibrosed, only then repeat vaginoplasties. If it's badly fibrosed. And we've seen 1 or 2 cases like that, but then they've all come through with, sexual intercourse itself.
So what are the parameters to be matched?
Okay, the parameters to be matched is first blood group. 2 is donor-specific antibodies, HLA matching. There is HLA representation, class A and class B in the uterus and the endometrium. So HLA matching is very essential. And we have as I said, Dr. Pony, which is Dr. Joy, who takes care of that for the donors and the recipient. And then the main screening which goes on is the vessel size. You have to, for the donor, she should not have diabetes and hypertension because it's called as atherosclerotic changes in the vessels, which will lead to hyperperfusion. And you have to understand that Asian women vessels compared to Western women, looks like we have more of atherosclerotic changes in our vessels, and we might have more problems in failure of the graft compared to them. And all these 4, 5 things. And of course, you have to screen them thoroughly. Don't miss out on torch. Don't miss out on, seropositive or seronegative. All these things should be completely screened. We did it twice for the patient. One when they came in, which was like 2 years, 3 years we've been following, and one just before the transplant, a month before.
Okay. So what is the ideal age? Like, see the one patient who you were screening, I think I did an IVF, the oocyte pickup for her,
Yeah.
but she, unfortunately, she was already 39. Okay. So as we know, that is the AMH will be low in patients with Mullerian anomalies for whatever reasons, maybe vascular. Or, that is something which I have observed, that when there is a Mullerian abnormality, especially when there is an absent uterus, their AMH and the reserve is already low. Okay. So if if the patient, like now, there is definitely so many support groups and there is awareness about Mulian anomaly and MRKH. So do you think, like, people should be sensitized about it so that they do it at younger age? Is there a cutoff where the government has put in a rules and told that you can't do it beyond a certain age?
Yeah, madam. It is the international protocols that we are following. Don't do it, uh, above 40. 40 is the cutoff, 18 years to 40 years. One of the same reason which hold good for IVF is the same thing, because ultimately we want to have a baby. So their fertility level better be really good, and plus as they age, their vessels are not that great, they might succumb to other infections. So less than 40 is the cutoff for the international standards, and that's exactly what we're following in India as well.
So, what's the role of immunosuppression? I mean, is it as stringent as like in renal transplant? Like, how do you do it?
So this immunosuppression, after the patient is admitted, 2 days prior, we give them induction. The first step is induction with thymoglobulin, 2 doses. And then we did 1 dose before and 1 dose during the surgery or immediately after. And then it's a triple drug therapy. So induction protocol is with thymoglobulin, and the triple drug therapy is azathioprine, tacrolimus, and steroids, and keep the TAC level between 5 to 8. And basically, you have to have a very good transplant physician. We have Dr. Joy, of course, and we didn't have any problem. So you have to have a very good transplant physician who actually checks their TAC level. For the first few weeks, we're very paranoid. See, it's our first 2 cases, right? Obviously, the paranoia will be, you'll want to keep looking at the patient like every hour. So we did we did the test a little frequently for the tacrolimus, the TAC level, to check, and we kept adjusting so that we are into the range. Because if we go down, we would increase the dose. If we go up too much, if the TAC level went like at 9, we would reduce the dose. And then we saw opportunistic infection. See, what really we faced was bacterial infections, okay? Which I don't think the Western world face. They face more of viral infections. We face more of bacterial infections. So it's definitely different for, the scenario is definitely different in India. So, I had a discussion with the Pune group as well, and they had the same, they came up with the same thing. So our protocol has to be a little more tweaked, and we've involved the infectious disease as well, so that we tweaked our protocols. We didn't face any viral infections at all post-operative. And of course, the biopsies have to be done very frequently. Biopsies, as I said, we once a week we did cervical biopsies for the first 1 month, and then once in 2 weeks for the next 2 months, and then once a month. Even during pregnancy, you have to do a biopsy, and that's why we got the instruments from Prague, where the biopsy was the biopsy instrument, I can show it to you later. I can put it in the groups. Biopsy instrument was much smaller and caused lesser damage to the cervix.
Okay. So, what is the role of robotics in transplant? Like, is it?
Okay, this I have to tell, compared. So we wear the loops, right, while we are doing the transplants, all transplants. So my first loop was gifted to me by Dr. Jerry Fronek. But though it was larger for my face, I still use that. But loops, of course. But what in robotic, I think what Dr. Max also says is robotic gives you a better dissection, okay, of the vessels. So when we are doing the anastomosis, it's much, much better because we've dissected out it so perfectly and beautifully, because the magnification is better than laparoscopic any day. That's what he says, because he's a lap surgeon and a robotic surgeon. He does both so fine. And he says robotic is any day better. And that is what world around, all the people who've used laparoscopy, robotic, and open surgery have told that across, be it US, Dr. Matz, or even our Dr. Sailesh sir, they all said that robotic is the best. And our next transplant will definitely be in the next 2 months with Da Vinci XI system.
So, how do you monitor the patient after transplant?
The monitoring of the patient. So the donor was discharged. So two things: donor, recipient. Our donor was discharged by the 4th or the 5th day. They were not even kept in the ICU. They were shifted to HDU. Next day, straight to ward and discharged. They were super fine. We are monitoring them even now. They're doing extremely good. Recipient, of course, we have the best ICU facility, liver transplant ICU facilities. So, with the best HEPA filters and all. So they were kept there with the liver team and monitored for 2 days in the ICU and then shifted to HDU and then to the ward. They were discharged one was discharged on the 5th day, one was discharged on the 7th day. So, and following that, they all lived very close. One, she stayed in our guest house itself in our hospital. The other was staying, really nearby. How you monitor is with biopsy and your TAC level. You have to take even vaginal swabs. You have to check their blood values for your TAC level is so important. And by the time your biopsies come, you'll always get a heart attack by then because it's so freaking horrible because you don't want rejection. You have to have a damn good pathologist as well who gives you the results right away in like 3-4 hours or so. We have a very good pathologist. And this is how you monitor. So, you do weekly tests for the TAC level, weekly biopsies for the first 1 month, once in 2 weeks, then for the next 1 or 2 months, and then monthly till and through pregnancy. Even in pregnancy, people have had rejection. So we'll have to be careful. We cannot say, okay, once they are pregnant, we are through. And for all our patients, for our donors, I forgot to tell you that we did a hysteroscopy, just to ensure before. I don't think other teams did it, abroad or whether they've not documented, but we did hysteroscopy just to make sure that things were fine. And we put these donors, both our mothers, the mothers who donated it, were postmenopausal. So we put them on 3 to 6 months on hormonal therapy. And we saw how they menstruated. They menstruated for 4 to 5 days, so they were responding. So we have to prime them, before we do. 6 months prior or 3 months prior, we have to give them withdrawal bleeding hormone replacement therapy to see how their uterus is functioning.
Okay, so where do you anastomose? Like, what do you anastomose in the procedure? What vessels do you anastomose?
Yeah. So the dissection for us, before I said, I don't know how many hours everybody took. There are people who've taken 4 hours, but we went very slow. Upper surgery almost took around 10 hours, a second surgery. I'm talking only about the donor. Totally, it was 16 hours of surgery, and we did back to back. 16 hours first and 15 hours second. It went really long. I'm sure other people have done 4 hours, but we went really slow. We wanted to get it really right. I think with robotic, we are anticipating it will be 1/4 of the time that we did it for open surgery. Okay, coming back, what is the vessel anastomosis? We need both the ovarian veins, both the uterine artery, okay, and the 2 uterine veins. You dissect it. If you want, you can take a little bit of the iliac, a small segment, okay, from the donor. To the recipient, external iliac artery and external iliac vein, anastomosis. So, and we did it, the anastomosis was done with 7070 Vicryl, Proline, or Vicryl you can use. So we did it with that, and yeah, that's about it. And vaginal anastomosis, of course, you do it in, just as we, with low.
I
Yeah.
think renal transplant now is very, what do you say? Now it is kind of like, standardized, and the results have been extremely promising when we talk about the renal transplant, and there is so much advancement and all that. So why is it, do you think, like the uterine transplant, I mean, though it made such a hue and cry in the beginning when Dr. Matt Bronstorm did it, and then suddenly there is a lull that, like, nobody is talking about it. So what do you think, like, I mean, where do you think, like, we all went wrong, or where do you think, like, the lacunae is, which can be is it the nuances in the procedure itself, or is it not lucrative enough, or is it not, like, there are easier options? Because this, I know, is like, something which is very elaborate. So, what do you think is the reason that it has not really become such a accessible thing for everybody?
One is the team, madam. Let me do it stepwise. First thing is, they've done more than 150 transplants across the world. Two is the licensing is so difficult. Three is the teams to come together. You always have to understand humans working as a team. You have like stalwarts working. You see liver transplant, liver transplant physicians, liver transplant surgeons, renal transplant surgeon, plastic surgeon, vascular surgeon, gynecologist, intensivist. You cannot bring such a big team together first. Teamwork is really, I'm going to be very honest. Let me be candid here, okay? So teamwork is something that you really cannot do so easily. Everybody cannot have the same, mind, wavelength and all. So that, I think primarily people will not talk. That is the one. Maths has done an excellent job. And, there are more than 70 babies right now across the world. And many more pregnant, 20 or 30 more. And I would say it is going. The why it is not, because you don't have the right people to do it. Nobody wants to fail. It's just, though it's been, actually it's a decade. Sir is doing, Matt sir is doing a paper, a decade of transplant, where we're all pitching in and writing. So it's been a decade, but you're right. I think it's not an easy cup of tea. Like, I'm not going to say others, liver or renal is easy, but our depth, our pelvis is really deep, all right? To get the group coming together is really, really difficult. It's not an easy thing, And the third thing is our arteries and veins are really coiled up. It's not like, you don't have like one chunk, and monitoring it like any other things, you can put a Doppler in. You have to have very good intensive, intervention radiologist. Also, now they've suggested, it's a little difficult to actually monitor the hypoperfusion. You can monitor others and all we've cracked, but the perfusion, and finally what really gives up is fertility itself is only 50 to 60% success rate, IVF, right? That's where we cannot give 100% success. And but surprisingly, the number of inquiries are quite high. So compared to the number of teams which came together are really low. I think it's just about time. I think in the next 2 years, I think there'll be many, many, many more centers. And I think in the first decade, it took so long. I think we'll double the numbers in the next 2 years. I'm pretty sure of that.
So how is the pregnancy rates among this 150 transplants which have been done?
Yeah,
So
more than 60 odd, I said close to 70 babies, and many more pregnant. As you know that even if the transplant is successful, right? It's the babies, it's the IVF which really, or if we had infection, right? So endometritis and hypoperfusion. We faced hypoperfusion as well. So our vascular anastomosis, like we had an hyperemic graft in the first thing, and we were the first ones to use in the world allogenic bypass graft to save the graft on table. But then everybody is having their difficulties in terms of perfusion, and that's where we're getting Dr. Matz to actually help us do the whole thing. Yeah.
So the complications you said is bacterial infection which you faced and hypoperfusion. So
Yeah.
how do you differentiate between how do you recognize hypoperfusion for that matter?
See, that's a tricky thing, ma'am. So I asked everybody, how do you actually diagnose? One is, they say, why don't you put, there are something called Doppler rings that you can place it around the arteries when when you actually place it, you can see the vessels, right, in the Doppler. So you need a very good intervention radiologist there. Number two is hypoperfusion will be very patchy. So basically, these patients will have first 2 months, somehow with the collaterals, but then they'll menstruate. But after some time, because of hypoperfusion, your embryo transfer will fail.
Yeah.
It's going to fail. And that's it. You might have a successful transplant, but no babies. And then
So,
the graft gives away hypoperfusion, and then you'll have to definitely sit down and choose, and you'll have to tell, yeah, we have to remove the graft. And by the way, the suture material we used was 7-proline, not Vicryl. Yeah.
so what is the fetal outcome when you're doing immunosuppression during pregnancy after the transplant? How is it?
Madam, let me tell you very clearly that these three drugs that I told you, right, has had no bad effect on the fetus, not even like IUGRs. All right. Earlier, they said, let's do a section at 34 weeks initially, because everybody's scared. Like how when they had their first IVFs, decades ago, they want to do a section. And now you and me changed it to 40 weeks and we deliver them vaginally, right? We can't do vaginal delivery for these patients, definitely not. Anastomosis will go for bonkers. But section at 37 weeks, yes, it's come down to that. But these three, tacrolimus, azathioprine, and steroids, they didn't have any effect on the fetus. It is not fetotoxic, proven.
Okay.
Because the
So,
dose is very less, ma'am, compared to
yeah.
what they use in hand transplant or other transplants, which are life-saving.
Yeah. So I think we have overshot our time. We, in fact, wanted to finish it in 20 minutes, but it's been 40 minutes.
Oh, sorry.
But I think this was one of the very, very, very interesting sessions I've heard about uterine transplant so far. So, Dr. Jai, would you want to add anything to this?
No, I think thank you, Dr. Shilpa and Dr. Padmapriya, for this session. But I think there is one important thing which people who are doing vaginoplasties should keep in mind as far as transplants are concerned. And I think we had a discussion on this in AICOG as well when Dr. Puntabekar was moderating my surgery for vaginoplasty, that the breadth at the apex of the vagina is something which is important and it has to be kept patent. So I think one of the most biggest problems which people see when they do a vaginoplasty is because there is no muscle which is present in order to line the vagina. We need frequent dilatations. And this dilatation has to be appropriate enough because initially your length will be formed. And once this length is formed, and then if it is not kept patent, then it will be some trouble as far as doing transplants or any form of activity at the vaginal apex is concerned. So as far as possible, I think probably the future is such that probably everybody would shift to using a double ileal loop in order to ensure that the vagina is formed out of muscle. And that loop would almost never undergo stenosis and keep the vagina patent, or probably a sigmoid vaginoplasty, which we use for gender reconstruction. But I think this is just one take home point for routine laparoscopic surgeons who are doing vaginoplasties because momentarily you will achieve a vagina. But if you look at the long term follow ups of these vaginas, there is going to be some cicatrization which is going to occur somewhere, and that's predominantly due to lack of muscle.
Yeah. Okay. So thank you. Thank you, Padmapriya. I mean,
Thank you, ma'am. Thank you
yeah,
very much.
thank
Take
you.
care of those two patients, ma'am.